All right. Hey, and thank you. My name is Beth Sievertson, and I am the medical ethicist here at Grady. I am also a certified critical care nurse, and so I've been asked to teach the ethics and professionalism section of the CCRN review course here. I'm going to go ahead and share my screen. And the plan will be, I'll go through kind of some of the concepts with that they want you to, let me just switch these settings. So we'll review some of the concepts that I know that they ask about on the exam. Some of them are a little more esoteric or theoretical, but in the meantime we'll also talk about real life examples so you get as much out of this review as possible, both for passing the exam and for your practice as a nurse. And then I'm going to break the sections up with example review questions that I took from just this Kaplan book I have. And so there will be an opportunity for you to quiz yourself as we go with these review questions. And certainly if there's a need for further discussion or explanation, please let me know in the chat. For everyone that might be watching this as a recording later on, you're welcome to reach out to me. I hope everyone finds ethics as fascinating as I do. Once again, I am a former trauma and surgical ICU nurse, still occasionally practicing. And so I am certified CCRN, and I've actually taken the exam twice. Right around the pandemic, I decided I didn't want to try to count up the 100 hours of continuing ed credits that they require for recertification. So I opted to go ahead and take the exam again. So I'm up for recertification again this fall. I'm trying to decide again if I want to take the exam or if I want to count up my credits. The idea of taking the exam instead of recertification came to me. I talked to one of the most senior nurses I used to practice with up in Boston, and she told me that she every 3 years takes the exam instead of trying to count up credits, which was an interesting option. I think there's a lot to be said for continuing nursing education, and I hope you all take advantage of those opportunities. But you should know that it is always an option to take the exam rather than trying to count up 100 hours of continuing eds in different realms of categories. So about the professional caring and ethical practice section of the test, these questions constitute about 20% of the exam and amount to about 30 questions. These range in scope from advocacy and moral agency of the nurse to what do caring practices look like, how to collaborate with your teams. Often, a good answer has to do with communication. Systems thinking, response to diversity, clinical inquiry, and facilitation of learning. It's expected that you're able to assess the entire patient and their situation. And so they'll want you to consider, the patient holistically on the exam, not just account for the strict physiological or clinical issues, but also thinking about the person as a human who has needs, and how do you take care of, the intangible needs as well as the physiological needs. So the exam talks about the synergy model for patient care, which to me seems very academic as a way to think about this, but it makes sense. A lot of this becomes common sense once you get into your nursing practice. So I think once you wrap your head around the synergy model, it makes sense. But it takes a little bit of understanding the framework of the synergy model in order to really absorb it. So the synergy model identifies that all patients have similar needs and experience these needs across a wide range And they have similar needs, but the patients are going to vary in so far as what need is stronger than others. Nursing practice is driven by the needs of patients and their family. That's the assumption here. You are seeking to address the needs of your patient and their family. And so that you're being able to address these needs requires that you are proficient in multiple dimensions of care. You know, not just titrating your drips or giving meds, but also understanding the body processes going on, and also being able to communicate to your patients and their family, as well as your team. You know, effective communication is as much a skill that is necessary in ICU care as, you know, being able to do all the ICU nursey things. So remember that this is a holistic picture here. There are 4 components in the synergy model. So there are core concepts, which we'll get in a second. Patient and family characteristics. Like I said, these characteristics, the needs and the variation of needs of patients and family are going to drive what we as nurses respond to. And then nurse competencies and characteristics. So you know your competency or characteristics across different categories are going to dictate how well you can respond to your patient's needs. So I will note that it's important for you to know generally that patient family characteristics and nurse competencies and characteristics feed into the synergy model. You don't need to know, you don't need to be able to name the different characteristics. Okay, just know that these are the components of it, and that ultimately the patient characteristics plus the nurse's skills will lead to outcomes. Okay, and we hope for good outcomes, right? So we want to be able to match a nurse's competencies to address the patient or family needs that are most prevalent. I hope that's making sense. Please let me know in the chat if you want me to slow down. I practiced as a nurse up in Boston. I tend to speak like an aggressive northerner. So I hope this will, you know, I'm trying to get through the material so that we can move on to practice questions. But please let me know if you need more explanation and I can back up. So given these 4 components of the synergy model, the core concepts, the patient family characteristics, and the nurse competencies and characteristics, all of those will drive the outcomes. So what are the core concepts of these? So 3 different core concepts. Like I said, the needs and characteristics of patients and families influence and drive the nurse competencies. So you may be competent across a broad spectrum of characteristics or skills, but that what skills you are using are going to be influenced by the needs and characteristics of your patient. Okay. Synergy occurs when individuals work together towards a common goal. Okay, that synergy basically means like meeting up and jiving, right? So we want to be able to work together and not against each other. So, and we want to be trying to achieve a common goal. Something I often talk about when I present to our nurse orientees is, you know, all I need is to understand my patient's why behind why they're seeking healthcare and what they hope for in life and good health. And that helps me adopt their goal. And then we're moving towards a common goal. But if my goal is different, if I'm just thinking about trying to get out of work at the end of the day, that's not the goal my patient has, right? So we're not necessarily going to achieve synergy or working together if we're looking for different goals. So, you know, I as a nurse seek to meet the needs of my patients. And for me, I need to understand what my patients' goals are in order to work with them. And frankly, that means having a better shift because you're not working against your patient, right? Or against their family. Active partnership between the patient and the nurse will result in optimal outcomes. So that kind of flows from what the other 2 concepts. So those are assumptions or core concepts here. Like I said, these are the characteristics of both patient and the nurse. These are not lists that you need to memorize, but rather just understand. And what there is to understand about this is for each characteristic listed here, there's a spectrum. And so a patient might be fully resilient, but not have stability in their life. They may be able to participate in decision making, but they might be very complex at the same time. And so we need to identify these different characteristics of our patients in order to adjust our characteristics to respond to their needs. Okay. And so nurses also have characteristics. And again, these are on a spectrum from a novice level of skill in this characteristic to an expert level. So we may be able to say participate fully in our caring practices. How do we show caring? How do we take care of our patient? But we might not feel very confident. We might still be at a novice level when it comes to advocating for our patients. You know, we might be able to respond very well to the diversity of needs presenting to us by our patients, but you know, we may lack or still be at a novice level when it comes to clinical inquiry or diving into, you know, reasoning through those physiological processes and understanding what's going on to address those needs of our patients. So I hope this makes a little sense here. Like, again, you don't need to memorize these. You just need to understand the nature of these characteristics and the fact that they exist on spectrums. For patient characteristics, this will be ranging from none to full, as in, you know, the patient's not able to participate in care, for example, or they're to fully participate in care. And then for nurse characteristics, the spectrum is novice to expert. So you can be a novice in collaboration, say, but be an expert in possibly being able to think through systems and adapt systems to needs. Okay, so like we said before, so we are working together, achieving synergy with our patients towards a common goal, and that will help us achieve optimal outcomes. So what are the outcomes we might talk about? So in the synergy model, the patient-driven outcomes are obviously, you know, functional changes, behavioral changes. You know, we see these in our patients. They start, you know, their body functions start to improve. They're able to physically function better. Behavioral changes, we might be able to stabilize their delirium. We might be able to reassure their anxiety. This may also have other outcomes may include comfort and trust. You know, the patient, by seeing you respond to their needs, will exhibit greater comfort and security in being in the hospital, and they will come to trust you and trust that you are looking out for their safety. And ultimately, we're hoping that the patient achieves an ideal quality of life, whatever that looks like to them, and satisfaction with their care. And so we deliver our care and we adapt our care in order to help patients achieve these outcomes. Our outcomes are, you know, adapting our practice to physiological changes and being able to address the needs of our patients in that way. We ideally want the absence of complications, right? We want to anticipate complications and address them where they present. And then finally, we want to talk about the extent that treatment objectives were obtained. So when we provide treatment, you know, we don't want to provide treatment that doesn't do anything. We want to make sure that our treatment is effective. And so we need to, you know, after we've delivered treatment, we need to stop and think about, well, was that effective? What, how much improvement did we see in the patient's condition? Finally, we look at system-driven outcomes. And if you've ever been a charge nurse, you know all about length of stay and readmission rates. So system-driven outcomes can reflect the quality of our care of our patients. Like I said, the assumption is that we are trying to address our patients' illnesses. We're trying to promote health and well-being. And so, you know, we might look at things like readmission rates or length of stay as outcomes of potentially not adequately addressing those needs. Also, resource utilization is a big concern, especially for us at Grady as a safety net hospital. we need to recognize that we are stewards of a scarce resource. We're reminded every day that there's not enough healthcare to go around, and it's very expensive. And so we need to be wise about how we're using that. And that includes our time, right? We, as ICU nurses, we are very aware that we have finite time in the day and we can only do so much. And so are we using that time efficiently? That's an outcome as well. Are we using our nurses' time wisely? And so these are all outcomes, and I'm just going to skip back to this slide again. Remember that the outcomes are one of the components of the synergy model that's hopefully resulting from our competencies meeting our patient and family needs. Okay, so let's get to the questions. Again, this is kind of a framework that I don't necessarily use consciously in my day-to-day practice, but I think it does become common sense once you understand it, and you can start to recognize how you're adapting your care management of your patient to their needs. So I'll read this out loud, and you guys are free, everyone who's on can, you can either write down your answer for yourself, or you can put it in the chat. But I'll read through this and then finish with answering it for you, and we can talk through the answer. So which of these is not a main component of the synergy model for patient care? So A is core concepts, B is nurse competencies / characteristics, C is complexity, and D is outcomes. And so, again, I hope you guys are thinking through this yourselves, or maybe if you're watching the recording, you can pause while you think through it. But the answer is C, complexity. So complexity is not a main component. It is actually a patient characteristic. And that can, like I said, the patient characteristics are on a spectrum from none to full. And so a patient can be very complex, or they can be not, I don't know what the opposite of not complex is, maybe simple. No patient is simple, I guess. But you get the idea. Their management or their care needs can range from not very complex at all to very complex. So that's a patient characteristic. The patient characteristics would be the other of the four main components not seen here in the potential answers. All right, we'll go through this one. The charge nurse in a busy surgical ICU has just been notified of an admission from the OR. The patient has sustained multiple traumatic injuries and is requiring constant transfusion of blood products, vasopressors, and IV fluids. Yet the patient continues to have labile vital signs. Which of these nurses should you assign to care for this patient? I'm going to talk through this. You guys can read the answers as I talk a little bit, but I just want to, get you thinking. Remember, we need to talk about addressing or fine-tuning the characteristics of the nurse to address the needs of the patient's characteristics. So think about the characteristics of what nurse can best address this patient's needs. And again, this patient being very labile and with the potential to spiral down the drain very quickly. So A, who would you assign to care for this patient? A, the new graduate nurse with 6 months experience, as it will be a good learning experience. B, yourself, as you already know about these procedures. C, the most senior nurse working in the unit that shift. Or D, the nurse whose characteristics best meet the anticipated needs of the patient. And so I kind of, in describing what we're trying to achieve here, I kind of gave away the answer. And I hope that, as you guys take this exam, you take your time and read through all the answers, because I'm hoping it's pretty clear what answer they want if you understand the synergy model. So the answer is D, the nurse whose characteristics best meet the anticipated needs of the patient. A, the novice nurse is not going to yet possess the skill and competency to best address the patient's needs. Yes, it might be a good learning experience for the nurse, but that's not going to fulfill the patient's needs. And so we want to focus on patient-centered care here. B, the charge nurse may not be able to meet the patient's needs better than another nurse working. And so, generally the charge nurse should not take primary responsibility for this patient, as it will interfere with other duties, is the answer. And then C, the most senior nurse may not necessarily have the best characteristics to meet the needs of the patient. So the answer again is D. And I think we have one more of these questions and we'll move on to the next section of content for review. So here's another question. A critical care nurse focuses her education on a patient with congestive heart failure to prevent future deterioration and promote symptom relief that will help the patient have a better quality of life. Using the synergy model, which of these outcomes encompasses preventing future hospital admissions for CHF? And so think back to those different types of outcomes we went through. And so we have A, patient-driven, B, nurse-driven, C, system-driven, and D, professional accountability. And so the answer here is C, system-driven. C, system-driven outcomes relate to the broader healthcare system because, this patient, yes, the critical care nurse is attempting to educate the patient about their CHF, but really ultimately it's going to be a reflection on the system of supporting this patient beyond in the ICU and beyond that prevents future hospital admissions. Just keep in mind the three types of outcomes we reviewed are patient, nurse, and system driven. Professional accountability is not an outcome here. And then, yeah, we'll move on. Okay, so the next area of content is going to relate to the idea of delegation, scope of nursing practice, and legal obligations of the nurse in practice. So let's talk first about delegation. So you need to understand when it's safe to delegate a task to, say, a nursing assistant or a tech. The fundamental principles apply here, including protection of the health, safety, and welfare of the public / your patient. And so we want to make sure, yes, you're busy, you have a full shift, you would accept any help that can come your way. But in the meantime, we want to make sure that we prevent any harm from occurring to our patient, and that this really, when we delegate things to assistants, that we are taking account of and taking responsibility for that being done right, even if we're not doing it ourselves. So the decision whether to delegate is based on your judgment about your patient's condition and their needs, again, relating back to that synergy model. So you also need to understand the competence of the members of your team and the degree of nursing supervision that might be required with this task. So again, similar to medication administration, we have 5 rights here. Going down the list, you want to make sure it's the right task. It's the appropriate task to delegate. Generally, a turn, taking vitals, things like that are delegatable. I don't even know if that's a word. But ultimately, you are going to be responsible if you ask someone to do something that is out of their scope of employment. 2, right circumstances. It's the appropriate setting and resources are available. It's your obligation to make sure that this is the appropriate time and place to ask someone to do a task for you on behalf of your patient. So if your patient is wildly unstable and you ask your tech to turn your patient, that might not be an appropriate delegation. In addition, skipping down to number 5, I would hope that to supervise that. But if your patient has, say, labile blood pressure and your tech goes to put their head of bed down, that may in and of itself cause some changes in your patient's physiological condition that you might need to immediately assess and address. And so you need to have an understanding of the setting and ensure that it's appropriate to delegate to a tech that might not be able to manage that as closely and appropriately as might be needed. You should make yourself available in that case. When I'm performing nursing care with a tech, I have eyes on them at all time with my unstable patients to make sure, my lines aren't getting caught up when we turned, the trach isn't gonna get pulled out. I know where all my IVs are, I know where my PEG tube is, because I really don't want harm to come to my patient because, this turn was done quickly and without a full awareness of what that patient has going on. Number 3 is the right person. The right person is delegating the right task to the right person to be performed on the right person. That's a lot of persons in there, but basically, it's not your place as, you may be an ICU nurse, but you might not understand your neighbor nurse's patient. And so it wouldn't be appropriate for you to ask your tech to turn a different nurse's patient because you do not have a full awareness of what's going on. I mean, unless you're the charge nurse, you don't have a full awareness of what that patient needs and whether this is a safe situation to delegate within. So, you can delegate for your own patients. I think it would be totally reasonable, if you're trying to assist your neighbor to ask a tech to take another nurse's patient's blood sugar, maybe that could be appropriate. But again, you need to be thinking through this so that you ultimately are responsible for the right situation taking place. I don't know if I'm saying that clearly, but I think you might get the point. You want to make sure that you are fully accountable for what is about to be delegated. Number 4, the right direction and communication. You need to make sure, you don't just delegate a task to your tech or assistant. You need to provide some instructions and a clear, concise description. I'll just read the slide. A clear, concise description of the task, its limits, its objective, and expectations. And so, this goes along with that example of turning my patient. If I need help with my second patient's bed bath and I ask a tech to help me do that while I'm finishing hanging a drug in my other patient's room, can you go ahead and start this bed bath? I make sure that tech is aware of everything going on with my patient. Hey, my patient's been a little delirious. Let me know if they get a little squirrely. I can come in and bolus them if you worry that they might be getting a little too agitated. I would not go ahead and turn without me. Please wait for me to turn because the patient has a lot of lines that need managing and I want to make sure nothing gets pulled. That sort of communication, you want to give a full picture of what limits you need to set on that task, not just in your head, but you need to communicate that to your tech too so that they're aware. And finally, the right supervision. They didn't provide, and again, I'm taking this from my review book, they didn't provide much description as to what constitutes the right supervision in different circumstances. I think, it's probably a little much to say you need to supervise every blood glucose draw that's happening point of care at the bedside. But at the same time, if you ask your tech to give your patient a bed bath, and yet your patient is wildly unstable, or maybe is on CRRT and has, big whopping lines full of blood that could get pulled, you might want to be in the room supervising that as opposed to outside at your desk documenting while that's going on. So the degree and the proximity of supervision, I think, might be what they mean here. There are certainly tasks that the tech should be proficient in without direct close supervision, but there are probably other tasks that are within the tech's scope of practice that do require some more direct supervision by the nurse. Again, this section is more on legal and clinical professional guidelines, and we'll skip through these. Well, we'll get through these and move on to some practice questions. But let's also talk about some adverse events or errors. Again, we're talking about your professional responsibility and legal obligations in taking care of your patients and keeping them from harm. And so CMS, the Centers for Medicare and Medicaid Services, provide reimbursement, federal reimbursement to hospitals. And if you don't do anything else, you should. We like them for the care that we provide. However, CMS has actually my computer, my internet connection is unstable, so let me know if I start breaking up. So like I was saying, CMS reimburses our care with federal money. However, CMS has given us a few examples of what they call never events. And these are serious and costly errors in delivering patient care that should never occur. Their categorization of these include CLABSIs or central line bacteremias, as well as pressure injuries, HAPIs, CAUTIs, urinary tract infections associated with our catheters. And really the idea behind CMS refusing to reimburse for these things is the idea that these infections should occur with good nursing care or a safe care environment. And so this is really, their refusal to pay for these things happening drives us to prevent them from happening. It's really CMS putting their foot down and saying, no, this is preventable and shouldn't happen. You as a hospital need to take accountability for this and your good practice. And so a never event is an error associated with a healthcare setting causing infection. Here, we want to identify that it is our professional responsibility to create a safe work environment, including being able to talk to other providers in the healthcare setting to try to help reduce or prevent these events. And so all that's saying is you need to take ownership of your professional practice and advocacy. And if your patient has a urinary catheter, you need to recognize that catheter, every day that catheter is in, exposes this patient to a risk of harm through urinary tract infections. So you need to be having these conversations proactively with the care team as far as, is it appropriate to maybe DC this catheter today? Same with central lines. Your patient has been weaned off vasopressors, they've extubated, you don't really need sedation anymore. Do we really need this central line anymore? Can we take it out? And so really taking a proactive advocacy role in the care of your patient in order to protect them from the harms that we know occur by, prolonged use of a central line, a urinary catheter, not moving your patient. A lot of critical care nurses, I think, are worried about causing harm to their patient by turning them when they're unstable. You have a patient on 3 pressors, they're on CRRT, maybe I shouldn't turn them every 2 hours or that'll just cause them to be more unstable. But we have to recognize that foregoing that turn exposes our patient to risk of pressure injuries as well. And so, is it actually manageable? And again, this comes from your skill and your proficiency in taking care of your patient. Can you manage that instability with a turn and reduce the risk of pressure injury to your patient? You can really step in front of your patient and anticipate what's going to happen. You can take measures to support your patient and keep them physiologically stable and still turn. Turn that pressure up a little bit if they're going to drop your pressure. If they're going to drop their pressure when you turn, there are things that you can do to do that and still turn. It's not a reason not to turn. And so, really your expertise developing that proficiency leads to better patient outcomes and also helps prevent never events. If an event occurs, it's important to evaluate how it occurred to determine the primary cause of the event. I'm not sure if it's trickled down to the bedside, but there was an email that just went out last week about the fact that Grady is embarking on our high reliability organization journey. And all that means is, HRO recognizes that medicine is a human endeavor, and humans are prone to errors. We are not 100% to prevent those errors from reaching the patient. And so when an error occurs or an event occurs, it's really up to the hospital to take a look at what happened. And, we shouldn't be, wagging our finger at the nurse saying, how dare you let this happen? We should be looking at what in the system and the sequence of events led to this event happening. So like I said, maybe you as a nurse don't feel confident in turning your patient because you're worried that they're going to be unstable, and thus your patient gets a pressure injury. Rather than, saying, how dare you let your patient get a pressure injury, a fair and just culture would look at the elements involved in, maybe you're not feeling confident to turn your patient. Did we have resources available that might help you feel a little more confident? Do we have, enough techs on that day? Did we have enough supervision from maybe a more senior nurse or someone more skilled at managing that kind of situation? And so rather than, like I said, rather than just blaming someone for an error, we want to make sure we determine the primary cause of the event. Ultimately, hopefully, we can change the system to help that event not occur again. Professional liability. Now, I'll tell you guys, I am a surgical trauma ICU nurse, going on 9 or 10 years. But I once went to a year of law school. It was not for me, hence why I didn't stay in the legal field. But one thing that drives me crazy these days, in my role as ethicist, I talk to a lot of people, and it drives me crazy to realize just how worried healthcare providers are about being sued. I think people, just generally, healthcare practitioners think they could get sued over anything. And maybe that's true. We have crazy people out there that are just looking to file a lawsuit. And if I'm being honest, I have told myself, if I ever have the opportunity for a windfall of money coming into my lap, I'm going to take it. But on the other hand, you need to understand, and hopefully this will help you practice more confidently. You need to understand that for you to be held liable professionally as a nurse, you have to meet these 6 criteria for negligence or these or even worse, malpractice. But so if any of these criteria don't exist in a circumstance, then the odds are that suit is not going to be successful. And so for negligence to be found, there must be found a duty to protect the patient from unreasonable risk of harm. So as a nurse, that might go unsaid, but they have to establish that it was your duty to protect that patient from unreasonable risk of harm. There are different types of harm that might be more reasonable in the course of a complex ICU care, a hospitalization. So understand that there must be first a duty, and then second, there must be found a breach of that duty. So you must, as a nurse, you must be able to, they must be able to prove that there was a failure to do what a reasonable nurse would do under similar circumstances. So that breach of duty also must be proven. Further, number 3, approximate cause must be found, and proof that the harm to the patient was preventable, and your failure to do what a reasonable nurse would do directly resulted in the harm that occurred. Okay, sometimes, we're looking at a situation and a patient suffers a harm, but, the proximate cause may not necessarily be your failure to give heparin that day or something like that. There needs to be a very clear correlation or causation proven. Fourth, there must be harm done to the patient. If there's no injury, if the patient doesn't suffer harm, then there's no negligence. There's no suit there. Direct cause of injury. This was what I was saying with proximate cause, proof that your conduct as a nurse was the cause or contributed to the injury. So, this is the point in which you might actually get dropped from a lawsuit because it's found that your actions did not contribute to the injury. And finally, there must be damages. Usually this is related to the extent of the injury, but the patient, if they're proceeding with lawsuit or the family must be able to prove that there was actual loss, damage, pain, or suffering directly caused by your behavior. So like I said, in the court of law, for you to be found negligent, all 6 of those things, all 6 of those elements must be proven by the suing party. And so that's a lot. It's not going to be, risk management will tell you differently, but it's not going to be, you failed to document vital signs every 30 minutes, boom, you're going to get sued. You have to directly, and you guys, I'm being facetious. That's just a silly example. But no, you have to then be able to prove that your failure to document those vital signs directly caused the injury that occurred to the patient. And so that's not going to quite make sense if the patient suffers an injury that has nothing to do with the temperature you didn't document at noon. So that's good to be aware of, because I think it helps you feel more confident in your practice. I see a lot of defensive medical and nursing practice going on. And I think that, if we're practicing like we might get sued at every turn, that really impairs and inhibits our ability to practice towards the goals of the patient and respond to their needs. So hopefully you can feel a little more confident in providing care, knowing that, it's actually a little harder to sue a nurse than just, saying you did something wrong. Malpractice is a specific type of negligence, and there's 2 types. There's professional misconduct, which is the improper performance of duties or the failure to meet the standard of care, resulting in harm to a patient. So an example of that might be, you didn't feel like turning your patient every 2 hours, which is known to be the standard of care, and you don't have a good justification. You wanted to sit on your phone, scrolling TikTok. That's a failure to meet the standard of care, resulting in harm to the patient, and you're not performing your duties. Malpractice is another type of negligence, I guess. Malpractice is the failure to utilize the prevailing professional standard, or the failure to anticipate the consequences of the nurse's actions. So malpractice would be, it is a set professional standard that before you walk away from your patient after a turn or after doing anything, you make sure that the bed wheels are locked, that the bed alarm is on, that the call bell is within reach, etc. Those are professional standards. If you have a patient fall during your shift and it's found that you failed to do those things for any reason, then you might be at risk for being found guilty of malpractice. Failure to assess a change in clinical status is another example. Medication errors, failure to notify the provider of changes in the patient's status. These are all professional standards that are drilled into us as nurses, and we should know. And so the failure to do the things to safely, give medications, to report changes in status, those are so serious a failure in our professional duty that you are then actually guilty of malpractice for not doing them. Okay, so some practice questions. So critical care nurses are accountable to ensure that they are practicing according to many rules, policies, and guidelines. Which of these is not an example of a directive that a critical care nurse must follow? So A, the State Nurse Practice Act, B, the ANA standards of practice, C, institutional policies, or D, instructions given by a nursing professor? I'm going to take a sip of water while you guys think. And so the answer is D. I hope you all got that. You are not professionally obligated to follow instructions given by a nursing professor. You are professionally obligated to follow state practice laws, professional society standards of practice, and your institutional policies. I hope that goes without saying. And again, when you're taking this exam, some of these types of questions are very easily answerable if you just take your time and read all of the answers. Think about the options and recognize that, you know, the nursing professor has no has no supervisory role over you unless you're a student. In any case, you're not legally obligated to follow their instructions. All right, another example, the Center for Medicare and Medicaid Services, CMS, has identified various errors made in the course of providing healthcare services with certain unacceptable occurrences resulting in non-reimbursement. The term for these errors is A, serious errors, B, never events, C, non-paying errors, or D, central line infection. So the answer here is B, never events. I would just advise, so D is an example of a never event. It's not the term they're looking for here. It is a type of never event. And again, that also includes CAUTIs, HAPIs, falls, things like that. For any of the care, for any of the care that needs to be provided after a patient falls, or, you know, all the antibiotics that are needed to address a central line infection or a UTI caused by a catheter, that is paid for by the hospital. We do not see any of that money. And so that's why we try to avoid these things as much as possible. And the reason, again, CMS does not pay for these things is because they recognize these are very preventable serious errors that should not occur in a hospital. All right, this one's a longer one. I'll read it slowly. A critical care nurse is busy with 2 critically ill patients in the ICU. Unlicensed assistive personnel has offered, that seems like a weird, has offered. So a tech has offered to assist the nurse by providing care to one of the patients. The task is within the scope of the care partner who has been appropriately trained, and the situation is appropriate. Remember the five rights of delegation. However, the nurse is not able to supervise as she is busy caring for the other patient. Is this an appropriate use of delegation? So yes, all conditions for appropriate delegation have been met. B, yes, the nurse is too busy to provide all the care herself. C, no, unlicensed assistive personnel should never provide care in the ICU. And D, no, the nurse is not able to supervise the delegated task, therefore delegation is not appropriate. And so again, you know, reading through all the answers can kind of help you eliminate some of them that are obviously not correct. So, you know, I would, if this were me, I would quickly eliminate C, because that's obviously not right. You know, text should never provide care in the ICU is not a correct answer. As well as B, I think is easy to eliminate, because, you know, no justification is going to, you know, be the right answer on the test that the nurse is too busy. You know, that's not a reason here. So, you know, those answers are a little easy to eliminate. The correct answer here is D. No, the nurse is not able to supervise the delegated task, therefore delegation is not appropriate. Remember the 5 rights of delegation, and right supervision is one of those rights. So if supervision, per the question, the nurse is not able to supervise. Thus, one of the rights is not met. As opposed to the first answer, yes, all the conditions for appropriate delegation have been met. That's not true here. So the correct answer is D. All right. One more question, and then we'll move on to the next section of content. Which of these should never be delegated to another healthcare worker, such as an unlicensed assistive caregiver? A, basic patient care activities such as bathing. B, any task that requires judgment, clinical or otherwise. C, documentation. Or D, answering telephones in the ICU. Once again, I realize, I've been in this testing situation and your nerves are running on high, and you're trying to get through as quickly as possible because you're worried about running out of time. Do take the time to read through these answers. Read through all your answers, because some of these questions are very answerable if you just methodically work through and eliminate some of the options. So it's an extreme question too. The never is bolded, and so you really want to take that into consideration. It's a little extreme to say a tech should never bathe a patient. We do that all the time. Or we have techs do that all the time. So that can probably be eliminated. Similar with D, answering telephones in the ICU. That's probably like a never, to say a tech never answers telephones, that's probably something that can be eliminated. So when I took this question, probably an hour ago, I was left with the 2, B and C, any task that requires judgment, clinical or otherwise, or documentation. The answer here is B. Any task that requires judgment, clinical or otherwise, should never be delegated to another healthcare worker, such as a tech. You are responsible for the judgments in care being made for your patient. C, documentation. It is okay to delegate some documentation to a tech, such as vital signs. We do that, right? Or maybe documenting that they turned a patient or bathed them. Documentation of assessments would not be appropriate by a tech, but to say that documentation is never appropriate to be delegated to a tech is probably inaccurate. So again, the answer here is B. All right, we're finally getting to what I do. So ethical issues. One second. Defined as the system or code of morals of a particular person, religion, group, or profession. And I like to think, we grow up learning our ethics or morals from usually, our parents, our family, our community, and often religion. We learn, kind of black and white rules such as do not kill, do not steal, tell the truth. These things, we're just taught at a very basic fundamental level, these are right or these are wrong. And so if you think about it, there's nothing to say definitely that killing is wrong. And in fact, if you think about it, we can probably come up with examples in which killing might be justified, such as self-defense or maybe, in acts of war. And so, we might disagree or agree on those things. So really, ethics is the system or code of morals that you yourself or your bigger community group might agree upon as being right or wrong or good or bad. The ANA Code of Ethics, again, similar to the Synergy model, has an underlying assumption that nursing as a profession and you are concerned with the protection, promotion, and restoration of health, the prevention of illness, and the alleviation of suffering. Those are the goals of nursing care. And so in all that we do, we should be trying to achieve one of those goals. And those are our North Star, our pillar of nursing practice. Examples of this coming up in patient care might be, should it be determined that the patient is DNR? And we'll talk about how this might be informed. Withdrawal of life-sustaining treatment. We start to ask questions about new technologies. Are these helping us achieve the goals of nursing, either through prevention of illness, restoration of health, or alleviation of suffering? And then new protocols. How are our new protocols that we either implement in nursing practice or throughout the hospital, how are these contributing to the goals of our nursing care? So a few concepts, and these are vocabulary words for this exam. I would advise that you do know these 8 words, and then there's subwords obviously here. But so the 4 core principles of medical ethics are autonomy, which is the right of the patient to self-determination. This calls for, it's been reconfirmed over and over again by the Supreme Court, but it's respect for patients' right to make their own informed decisions. This is the basis of informed consent and advanced directives. Often, or I won't say often, but sometimes the right to autonomy can come into conflict with beneficence. So on the flip side of this is paternalism, where healthcare providers make make decisions for the patient that they feel to be in the patient's best interest. This denies a patient's autonomy. So an example that I often see come up in my practice as an ethicist is that the doctor feels that the patient needs antibiotics to address their osteomyelitis, but the patient wants to go home and does not want to complete their course of antibiotics. The patient has a right to self-determination, and we want to respect that right and the need to get the patient's consent to treatment. But this kind of creates between a tension, not a tension. It creates a conflict between what the patient feels they want to do and what the doctor feels is best for the patient. That paternalism is often driven by the next concept of beneficence. And this is the idea that we want to do good, prevent harm, and promote the well-being of our patients. We want to make sure that any harms and benefits are balanced. And so, when a patient decides they want to leave AMA and the doctor's like, wait, come back. It's not because we want to tell the patient what to do. It's because we're trying to, act out of beneficence in trying to address the unresolved issues of that patient and prevent any harm from occurring. Now, skipping back to autonomy, we need to recognize autonomy, or their expression of autonomy, is something I'll often say, can be impaired by different things. And we often talk about a patient's capacity in that sense. So a patient may suffer from impaired capacity or a lack of capacity due to different things, including head trauma, alcohol withdrawal, serious septic infection, dementia. All of these things can impair a patient's ability to assess risks and benefits in treatment and be able to make decisions on their own behalf that will help support their health and well-being. And so when a patient might lack capacity for decision making, we need to try to identify that and speak up and advocate for that patient if we're worried that they're making, potentially poor decisions in the setting of impaired capacity. So we talked about beneficence too. So the idea that we want to do good wherever we can and prevent harm. On the flip side of that is the first rule of medicine dating back to ancient Hippocrates, saying first do no harm. We have a duty to remove a patient from harmful situations. So this might, you're walking down the hallway and you just glance in a patient's room that's not your patient, and you see a patient trying to get out of bed. You don't keep walking. Okay, you don't say, that's not my patient, I hope someone sees that. No, you stop and you go in and you say, hey, what are you trying to do there? Let's get you back in bed. So this applies to all of our patients, not just your assigned patients, but we have a duty to protect the patient from harm and to remove the patient from harmful situations. So non-maleficence is a core ethical principle. Justice, and this is, I spoke to this a little earlier, but this is the concept that healthcare resources are scarce. We don't have enough to go around. And because they are scarce and precious, we have a responsibility to distribute these resources fairly and equitably among patients or groups of patients. And it's especially important with scarce critical care resources. Luckily, not everyone who walks into the hospital is critically ill, but more and more our patients are coming in with complex disease processes and requiring more complex care. And ultimately, these critical care resources, the technologies and therapies that we're able to provide in the critical care setting, they are very finite. They aren't unlimited, right? And we need to make sure that we are managing them appropriately, responsibly, and equitably. And again, healthcare resources include your time. And so you as a nurse need to advocate for yourselves and your time and make sure that you're being efficient with your time as well, in order to provide the best care and do the most good with your time and effort. So I said the first four were kind of core ethical principles. The next four aren't core principles, but they're very much recognized as being essential to good ethical patient care. So futility comes up a lot in critical care, and frankly, this is what drove me as an ICU nurse to get into ethics. But it's the idea that care should not be given if it will not improve patient comfort or medical outcome. This is, a very blunt example is you have a viral infection. My giving you antibiotics is simply not going to fix that viral infection. That is futile. So that's a very strict interpretation of futility. In the ICU, we run into maybe a less strict or more broad idea of futility where especially after you get some experience as a nurse, you can look at a situation and think, no matter what we do here, this patient is going to die. And that can really weigh on you as a nurse, because you're putting, like I said, you are a scarce resource. And so you're putting all of your time and effort into something that you foresee is ultimately not going to have a good outcome or improve your patient's comfort. And that can really weigh down on you. And so we need to try to recognize futility where it exists. Again, there are strict interpretations of it, and there are more soft or broad interpretations of it. I think what's essential with the broad interpretation of futility is identifying what our goal in patient care is. We talk about goals of care all the time. And unfortunately, the goals of care are kind of boiled down to DNR or comfort care and things like that. Those aren't goals of care. No one has a goal of being intubated, right? A goal of care is, cure, treatment of illness, or comfort. And once we understand the patient or family's goal, and once we have defined that, then we can develop a plan of care that helps to achieve that goal. And so in futility, when we see futility, we need to stop because like I said, this can really weigh down on you as a nurse, but when we're concerned about futility, we need to stop and really make sure we've defined what our goal is. And, some goals might not be achievable. So in a patient's care, if we identify that cure or recovery to maybe discharge out of the hospital is not achievable, then we might need to sit down with the patient or family and reevaluate what our goals need to be. Because we should not be trying to trying to achieve an unachievable goal. Because that ultimately will lead to not using our scarce resources appropriately. So that can be really hard. Leading into this, so kind of adjacent to autonomy, is the idea of trying to prevent futile situations from occurring. We need to look at the patient's previously expressed wishes. What are their goals? When they were able to talk, what did they tell us was important to them, and what did they tell us would be acceptable to them? The patient can express these wishes or their goals of care either directly to us, in which case I hope you document these conversations and let a provider know. There's also, advanced directives where the patient can sit down in anticipation of something bad happening, or even just because, and they can kind of go through the advanced directive and say who they would want to make decisions for them and what care they would find acceptable. Similar to that is a living will or a power of attorney. Generally, the power of attorney, there are two types. There's financial and healthcare. We really only care about the healthcare POA. And the POA will generally not express wishes for care so much as appoint a decision maker if the patient's unable to make their own decisions. There's another slide coming up on this, so we'll get back to this idea, but substituted judgment. If we don't know the patient's previously expressed wishes, we look to people who know him or her well. We say, if the patient were able to speak, what would they want? Or have they ever talked about being in this kind of situation and what they would want? It's been a little while since I've reviewed the literature about this, so it may have changed, but most people don't want to be kept alive in a dependent state and dependent on machines. There have been broad surveys evaluating that, but ultimately we want to provide care that is in line with the patient's goals. And so we need to really seek to define what that patient's goals are, and then we'll have a trajectory to develop a plan of care for. Moving on, so the idea of veracity is your duty to tell the truth. And really this helps establish trust between you and your patient, as well as you and your colleagues. Accountability can tie into this, the idea that, if you need to be accountable for your actions, you need to tell the truth and be able to be transparent if you fear that you've made a mistake. And that is one, again, to build a strong foundation of trust with your patient, with the family, with your colleagues. And two, owning up and being accountable for potential mistakes or errors that you make help call attention to that so that we can move to prevent that mistake or error or harm from causing harm to the patient. So veracity is very important. Some cultures may not value informing the patient of his or her diagnosis. Occasionally I had an example of this a long time ago, but I had this elderly female patient who had just been, via CT, we had identified that she had a new diagnosis of cancer. And her son really pled with us, saying, you can't tell my mom about that, like it'll destroy her. And he very much, he strongly said, she's been asking me to make all of her decisions for her, like, you really shouldn't tell her this. And really there is a way around telling her about that diagnosis without breaching that trust or that request of the son, which is, going to that patient, to your patient and asking, hey, how much do you want to know about your own care? And maybe starting it like that, because she may very well say, all of this has been so overwhelming. I would rather you talk to my son about this, about my care, and he'll help me make decisions. And so, at the end of the day, and I say this over and over again, I just need to know, the goals of my patients, or what their preferences are. And so long as, they can kind of give me a reason why behind their goal or what they're trying to achieve, I can get behind that, and I can shape my practice to support that. Moving on, fidelity is the idea of, as a nurse, I have a faithfulness I need to help support and foster between me and my patient. My patient needs to trust in me and know, faithful seems like a strong word, but they need to know I'm faithful to them and won't sacrifice their safety or their interests for other things that aren't in their interests. So loyalty, faithfulness, honor, and commitments, and that helps build trust and foster that therapeutic relationship. If my patient doubts all come when they press the call bell, they may very well not try to call me before they go to the bathroom and end up having a fall. And so they need to know that I'm looking out for them. If I don't respond in a timely manner, I'm the first to apologize and say, hey, I'm so sorry. I saw your call late. I was tied up, but I really wanted to get to you as soon as possible. That fidelity also means not ignoring requests for help, not blowing things off. We really need to strive to do the best for our patients, because that's what we try to do when we have loyalty to someone. And then finally, confidentiality is the idea that we need to maintain a patient's privacy by keeping information secure from unnecessary sharing. And I think we've all been through the mandatory annual education to this effect. But I hope you're all aware of HIPAA and the types of patient information that should not be shared, except for clinical needs. This is often, they give an example of this, but it's often challenged in cases of STD diagnosis. And that's, probably primarily referring to HIV diagnosis. The disclosure of HIV status is a call that, I, as an ethicist, will get every so often. I'll have someone call me out, usually a member of the care team call me up and say, hey, this patient has HIV. He, for some reason or another, is incapacitated in the ICU and unable to participate in discussions. His mother has taken over as his decision maker, and she does not know his HIV diagnosis. Is it okay to tell her? And just, again, it's confidentiality. We need to recognize that some pieces of our health background and information are a little more sensitive than others, HIV being one of those. HIV, more and more is treatable and preventable, but it still carries a heavy stigma. And, our patients, our patients with HIV may have preferences for who they share that information with. So I often coach teams that, unless it is absolutely necessary, meaning that the information that this patient has HIV is so material to being able to provide care to that patient, unless the mom has to know that HIV diagnosis in order to make informed decisions, we should not disclose it. We'll have patients. I had a recent example. I had a patient with bacteremia, and he's, profoundly sick, and he was getting CRRT, and the story was he was doing home dialysis, which, don't ask me how that happens. As an ICU nurse, I'm like, no, that's far too complicated for a patient to manage. But he was doing home dialysis, and he came in profoundly sick with bacteremia. And he happened to have HIV, and it was well controlled. He managed it. The team called me to ask if they should disclose that status to his mother. And I'm looking at this chart, and I call up the infectious disease service and I say, hey, I just want to understand, how much do you think this HIV, this infection is contributing to his current state? And I'm glad I called, because the infectious disease doctor told me, absolutely not. He's well controlled. We don't think he's immunosuppressed at all. We think, the ethical issue is that there's a nephrologist out there who allowed the patient to keep his home dialysis catheter in place for 2 years. That is definitely where the bacteremia is coming from. And so, in coordination with ID and the primary team, I helped them kind of determine that, sharing that HIV diagnosis with the patient's mother at this point would not be material to her decision making on his behalf, and thus it was unnecessary to disclose to her. Really trying to protect his privacy, recognizing that, that patient might have strong thoughts about whether his mom knows about his HIV diagnosis or not. And hopefully, down the road, when and if he recovers, we have the opportunity to talk to him about, if you were ever in this situation again, what would you want us to do? Would you want us to disclose it to your mother? Or, is there someone else you would rather have as your surrogate decision maker, that would know about that information and that we could talk to? Again, all coming back to, what is the patient's goals and what are their preferences? And again, I love this Nightingale quote, but Florence Nightingale said, it's a little weird that in a hospital we have to say out loud that first do no harm. But if you, again, medicine is a human endeavor, and if you think about it, we have the opportunity to do so much harm to our patients. So we really need to make sure that we're proficient in our practice and that we are safe, to the utmost extent. We cause small harms every day. We stick people for labs, we cut people open in surgery. We always want to make sure our harms are justified by anticipated benefits coming from those harms. So when we stick people for labs, it's not because I like sticking people for fun, but it's because I anticipate that this will help us diagnose disease or treat an abnormality. And thus the pain and harm inflicted by, sticking a human with a needle is justified because we anticipate a benefit. And then I'm just taking a look. We have 2 slides and then more practice questions. So an ethical dilemma comes into play when 2 or more of those principles on the previous slide come into conflict. And the only way to do something perceived as right is to do something that feels wrong. I always think of Aladdin when I think of this slide, stealing a loaf of bread to feed someone. You feel like you have to do something that you know is wrong, but you're doing that, you feel justified in doing that because you're hoping to achieve a right thing or something that is good, that balances out that wrong. So down at the bottom, you can see, like I said on the previous slide, patient autonomy sometimes comes into conflict with the principles of beneficence and non-maleficence. I had a patient once I was consulted on, came in with sepsis, likely related to a chronic foot infection, and he was told that really to achieve source control, he was so septic at this point, it was thought that what had been an ulcer that was infected on his toe had actually become systemic, and now his life was actually threatened, and that the only way right now to achieve source control was amputation. And he expressed a preference. He said, no, I don't want to, I don't want my foot cut off. And so there are a lot of things that come into play there when I get called about that, but recognize that his expressed preference was coming into conflict with this idea that, we can save your life, but we need to be able to provide treatment or, surgery to do that, which he did not want. The questions that come up for me in that situation are, is he of sound mind? Does he have capacity to make that decision? If he has a systemic infection, is it possible that he's delirious from that infection and not quite understanding that his life is at stake? Is there, if we find him to lack capacity, is there someone we can call, a family member or his surrogate, to represent his best interests and speak on his behalf? And so trying to find ways to mitigate this conflict as much as possible. On the other side, is surgery actually necessary? A call I'll make maybe to ID is, is it possible to stave off the need for amputation if we get antibiotics started? Can we avoid, overriding his expressed autonomy by seeking an alternative option for treatment? I'll often ask the surgical team or the critical care team, how emergent do you feel this to be? How sick is he? How quickly is he, is there a chance to stabilize him in order to better assess his capacity, maybe restore his capacity with some antibiotics, or else to talk to his family? So these are all questions that I start to ask when an ethical dilemma is called to me. Again, trying to mitigate that conflict, or at least like try to figure out where this balance comes out. I talked about this a little bit with futility a couple slides ago, but it's really important for you all to recognize that ethical dilemmas, or ethics in general, can seem like a little far removed from what you're doing. You have a million things to do in a day. And unless it's, drawing the labs or taking the vitals or hanging meds, like it seems like a luxury to be able to think about, am I respecting the patient's autonomy? I hope, as you master your practice, I hope things like ethical practice come as second nature to you, and you can do that without thinking. But I think early on in your practice, it's important to recognize that while other elements of care may seem more immediate and important, I have to get this ABG or else I'm not going to know how to treat my patient. Ethical dilemmas are the things that will stick with you long after you were assigned to that patient. And so, when you feel like you couldn't act ethically or you couldn't do the right thing, that's what's going to cause you to stay, like, that's going to keep you up at night. That's going to be the feeling you remember 30 years from now. And so it behooves you to take action and try to speak up for what you think is the right thing when you can, because you may come to regret it, and that's the type of thing that sticks with you. Moral distress is the emotional state that arises when you feel like the correct action to take is different from what you are tasked with doing. So you're either told to do something that you have questions about and you think might be wrong, or that you should do something and for some reason you cannot do that. I think a big source of moral distress can be short staffing. You feel like you want and need to take good care of your patients, but you have that barrier of not having enough people on to be able to do that. And so that can cause a lot of distress and really stick with you. Down the road, that can turn into moral injury. And even better, a term I like is the term moral residue. And so, that kind of, you think of residue, this stuff sticks with you, it builds up, and it's hard to get rid of if it gets to a point where it's like sticky and built up. So it really is, it's really important to try to address ethical dilemmas when you feel them arising. And in fact, it's part of the ANA Code of Ethics to do that, because that can really go to improve the environment of care and improve the care of your patient as well as your well-being. We have, I think, 2 more slides and we'll have our final set of questions. We talked about this a little bit with autonomy and paternalism. But I really like this graphic, and I think it helps kind of show you what's going on. So back in the day, And I'm not talking about like Hippocrates again. I'm talking about like 70 years ago. So like 1950s, 1960s is kind of when we started caring about what the patient had to say about their care. But before then, medicine was really practiced in a paternalistic manner. So, I forget what book, I think it was called The Cancer Ward, but, back, in the 1920s to 1940s, patients were diagnosed with cancer and then they were just along for the ride. They didn't know what was going to take place day to day in their treatments. They didn't know how long they'd be in the cancer ward. They were just there until the doctor told them it was okay to leave. And, they didn't know that they were going for tests until the tech came to pick them up. And even, back then it was felt by the medical community that informing the patient of their diagnosis might stand to make that patient even sicker. So in fact, it's better if we keep the patient in the dark and don't tell them about what's going on, because that will actually help them get healthier faster. Needless to say, we've revisited those thoughts. We think about this a little differently now. And so the gold standard for decision making is shared decision making. You can see that down in the bottom of this graphic. And so the idea is that the clinician, in talking with the patient, informs the patient of, the diagnosis, information about the disease, and, here are my recommendations for treatment. And then in turn, the patient informs the clinician of their values and preferences. Hey doc, I really want to try to get to my niece's wedding next month. Is this surgery? I understand you're saying I need surgery, but is this something that needs to happen now, or is it something I can do after that wedding? And so, that's a very kind of superficial example, but that's the shared decision making. It's taking into account the patient's values and preferences and adopting our recommendations to help support those preferences and meet the patient's goals. So again, gold standard for decision making is shared decision making, and usually that is with direct input from the patient. Now, if the patient cannot engage in decision making for one reason or another, we usually choose, the next standard. So not the gold standard, but the second standard is substitutive judgment. And so we look to a surrogate decision maker, typically a family member, to help tell us what that patient's values and preferences are. I don't know the patient can't talk to me, but maybe you as, his spouse or his child can help me understand what was important to him. And if he could talk, what he would want. And so, usually, hopefully the patients can, or hopefully the surrogates can help, engage in that discussion. But sometimes we get to the point where, the son says, we never had that conversation. I don't know what my dad would want here. In this kind of situation, this is when you might hear, whoever's leading the family meeting, or, palliative care doctors are very good at this, but, well, you might not know what he would want, but, tell me a little bit about him. What's important to him? What did he enjoy? And sometimes that can give you a sense, maybe if we don't know, the strict answer to, would your dad want a trach? And would your dad want to be on the ventilator? Sometimes, maybe they haven't discussed those questions, but the child can give us an idea of, oh, my dad's very active. He would never want to be confined to a room. He always had to be up and going. And he likes to, he always chats my ear off. And he would never be okay with not being able to eat something. That's not speaking directly to what the patient would want in terms of interventions, but it's telling me a whole heck of a lot about what's important to that patient. And then we might be able to, form a plan of care that helps, hopefully return the patient to a state that he would find acceptable. But, if we're looking at a situation where we're not sure dad is ever going to wake up again, then we might need to, again, reevaluate our goals of care so that, we're actually aiming towards an achievable goal and not shooting for the moon for something that frankly isn't ever going to be achievable. So that's substitutive judgment. Basically, tell me about what the patient would want, or can you help me understand what was important to the patient so that we can, make decisions based off that. If even that's unknown, the last standard and kind of last resort for decision making is called the best interest standard. Generally, preferences aren't known, but we look at the patient and consider what is felt to be in his or her best interest. I'll see this is the standard that we by default have to use when a patient has a state guardian. When a guardian is appointed, they are essentially a stranger to that patient. They are appointed by the state. They don't know this patient. They don't know anything about them other than, maybe what information is provided. And so we are left, not making decisions based on what the patient would want or what would be important to the patient, but rather what might be considered best interest of the patient. And generally, in most cases, the best interest of someone is to stay alive. That's putting it very simplistically, but when it comes down to it, generally, that's the agreed upon best interest of most human beings. So staying alive is generally the best interest standard, and treatment towards that goal, will be in line with the best interest standard. However, that changes, and we have to have these conversations with, state guardians all the time, where that goal is no longer felt to be achievable. Like, hey, Mrs. Guardian, we have provided full aggressive care towards trying to help this patient recover, and even that is not achieving recovery. We are afraid that this patient is dying despite our best efforts. And now, rather than, pursuing the best interest of, restored health or function, we might need to change course and instead talk about alleviation or prevention of unnecessary suffering. And really that's, in the setting, I try to couch this discussion in terms of, we do not want to prolong a dying process. We no longer think this is a process of recovery, but rather we think this may be the patient's dying process, unfortunately. And so we need to talk about how to limit pain and suffering experienced by the patient in that case. And so those are the standards of surrogate decision making. Again, gold standard is shared decision making. Next one is with surrogate decision makers helping us use substitutive judgment. And then the last standard is the best interest standard, which really isn't informed in any way by that individual patient's preferences or values. All right, so getting into our last three questions, and then we'll wrap this up. And I guess I can give you, I'll give you my contact information. I know a lot of people will watch this recording, and so you can always reach out to me if you have any questions about this. But so I think this is a third to last question. Which of these ethical concepts describes the notion that telling the truth is important when communicating with others, especially with regard to medical diagnoses or treatments? Is it A, veracity, B, confidentiality, C, justice, or D, beneficence? So I'll go ahead and answer, and the answer is A, veracity. Again, we've been through a few terms. The principles of medical ethics are something you should probably understand and know the terms for. So make sure you review those before the exam. So next question, a patient with advanced metastatic cancer is admitted to the ICU with sepsis and respiratory failure. His condition declines despite all available treatments, and he has required resuscitation for 2 cardiopulmonary arrests in the past 12 hours. The healthcare team meets with the patient's family and informs them that there are no more treatments available and the outcome will not change. Which of these ethical principles is guiding this discussion? Is it A, justice, B, futility, C, fidelity, or D, non-maleficence? And the answer here is B, futility. Remember that futility is the principle related to care that will not improve the patient outcome or comfort. Aggressive measures to sustain life in a patient like this one are often considered futile. All right, last question here. A patient with terminal illness has written a living will, specifying that no aggressive or heroic measures be implemented to sustain life or prolong suffering should she be unable to voice her wishes. This is an example of preserving the patient's right to A, stability, B, resiliency, C, autonomy, or D, confidentiality. All right, and the answer here is C, autonomy. And remember, autonomy is the right of the patient to self-determination. The patient gets to dictate what goes on with their body. We ask permission before we do things to a patient, okay? The first two answers, A and B, stability and resiliency, are, I'm referring back to this, but these are characteristics from the synergy model, not ethical principles. And then confidentiality would relate to keeping healthcare related discussions private in order to protect the patient's right to privacy. And so that, I hope, is understandable. Sorry guys, I'm having brain farts here. And again, I would review the principles of ethics, and I'll just go back to those really quick. So maybe these vocabulary words, you take a screenshot of this slide and just quiz yourself, make sure you know these. You can probably Google these words with clinical ethics to find other examples of these if you want to understand better how these apply in clinical situations. I went through a few examples. Now I'm just scrolling back to kind of review different slides in case you guys, haven't heard the whole presentation. If you want to, take screenshots of any vocabulary here. This is the slide with the 6 criteria for negligence. And then the 2 types of negligence which constitute malpractice. So just remember these elements of negligence need to be proven in order for someone to be found guilty of professional negligence. And then just going back, here are the rights as far as delegation go. And remember, the question that was asked, had that answer that asked that all the elements of delegation are satisfied, and just remember that supervision is an element that needs to be present when it comes to delegation of different tasks. And we'll go all the way back to the synergy model. Just remember there are 4 components to this: the core concepts, patient family characteristics, nurse characteristics or competencies, and outcomes of the synergy model. And I'll go forward to this one. Again, I get the sense that you need to understand the model, but you don't need to be able to recite the different characteristics, and then the 3 types of outcomes. All right, and that's all I have for you guys. I really I appreciate your drive to seek professional certification. I think the CCRN, taking the exam and studying it, frankly, made me a better nurse. It helped to inform my care, and I really felt like I understood better the physiological processes going on that I was providing treatment for as a nurse. And so I really feel strongly that this, studying for the exam is as important as having the certification. So I applaud all of you for pursuing this, and I wish you good luck, and I hope you do well on the exam. Sleep well beforehand. And again, I said this a few times, make sure you read all the answer options before you answer, because something might, you might go to pick one and then you might realize, having looked at all of them, that a different one makes more sense. These nursing exams like to trick you with that. Select the best answer option instead of, the right answer. And sometimes there are more than one right answer available. All right. Thank you and take care.
Thank